I am Walid Ali Abu Omar. I am, inshallah, will be the moderator of the today event with a great character in anesthesia. I think, inshallah, Dr. Haytham Algameel. He is a consultant cardiothoracic anesthesia and cardiac ITU in Aberdeen Royal Infirmary, associate lecturer in University of Aberdeen, UK. We are lucky to have him today, inshallah, and he will be a presenter for an interesting and usually conflicting topic in anesthesia. We are facing frequently, I think. It will be, inshallah, pulmonary hypertension. And as he, and inshallah, he will made it easy, inshallah.
So,
Welcome, Dr. Haytham. We are happy to have you today. And thanks in advance, inshallah. You can start, inshallah.
Thank you so much, Dr. Walid, and also for Dr. Mahmoud for inviting me and for encouraging me to join this actually lovely group. Thank you so much for everyone. As I mentioned, really, I appreciate that it's a time off and it's a weekend, so probably going to be a very precious time for everyone actually to take part of their time with their families, or maybe with their works, or maybe with their relaxing time, in order to join this really nice gathering and nice scientific activity. And as you mentioned, pulmonary hypertension, it's hard actually to make it easy, because it's definitely, as you mentioned, it's a very conflicting topic to talk about and even to deal with in our anesthetic experience in general, or in our theater. So let me share first the slides here, and we will take it from there. As I mentioned, pulmonary hypertension could be really a fear for most of us as anesthetists, in different degrees, definitely. Maybe as a cardiac anesthetist, we can deal with those things because we are observing this on regular basis in our theaters. But definitely, if those patients has been really engaged in any kind of surgeries, or went through any track apart from the cardiac theaters, probably going to be really a very, very complex surgery. And even if those been scheduled even for non-cardiac surgeries as well, going to be really a very tricky and very challenging as well in terms of the management, in terms even of the post-operative courses as well. So the pulmonary vasculature system, and that's the reason why we consider this really a very tricky, and why the pulmonary hypertension initially starts really to be prominent, because it's normally low. The pulmonary vasculature system, actually, it's a very low pressure and low resistance circuit. So any type of increase in the volume might really cause a dramatic increase, a surging of the pulmonary blood pressure. And that's why it's challenging for the anesthetist, because definitely we are going through many incidents, or like many situations during the conduct of our general anesthetics in general, that it might really cause that kind of increase in the pulmonary blood pressure. It might really even also have a very negative impact on the morbidity and mortality, especially when those patients underwent anesthetics or surgery. Even we should consider as well, and should expect, that those might really stay a little bit longer in the hospitals and in the ITU. Pulmonary hypertension generally is classified whenever you have a mean pulmonary arterial blood pressure above 25 millimeter mercury, especially at rest. And that what actually caused mainly by a combination of vascular factors like proliferation, or the factor that affects the arterial vasoconstriction, or maybe a lesion in the left side of the heart, or maybe some pulmonary vascular embolism or thrombosis as well. According to the WHO grading for the pulmonary hypertension in general. Simply, grade 1 pulmonary hypertension, whenever you have an idiopathic causes or like hereditary causes, or if it's caused by drugs, that it might induce increase in the blood pressure, pulmonary blood pressure in general, or diseases like HIV, or in cases of portal hypertension or connective tissue disease, which is mainly idiopathic or maybe considered a grade 1. The left side dysfunction is definitely categorized as a grade 2. And whenever you have a lung disease or hypoxic pulmonary disease, usually that actually be categorized as a grade 3, and definitely grade 4, usually concise to the thromboembolic diseases or tumor or anything might cause an obstruction. Another classification as well is whenever you consider the grades according to the degree of affection of the systolic and diastolic, if you can measure that. So the grade 1, usually considered mild, and whenever you have a systolic pulmonary arterial pressure varies from 30 to 50, this is considered mild. If it's from 50 and above up to 70 is moderate, which is grade 2, and from 70 and above 110 is grade 3, which is considered severe. And definitely if you have a systemic or the suprasystemic, which is grade 4, which means the pulmonary arterial blood pressure now becomes exceeding more than the systemic blood pressure. So this is considered suprasystemic. To be honest, you can also rely on the diastolic and the mean pulmonary arterial blood pressure, but definitely you will find that which is very common in most of the echo reports. Usually we rely mainly on the systolic, so systolic is more indicative. Here, whenever you have to go through the different grades, and as I mentioned, the grade 4 or the suprasystemic, which is severely actually might impact and might definitely should expect that this patient might have a right side heart failure. According to the severity as well, you can rely on the right ventricular systolic pressure, because as I mentioned, one of the main negative impacts actually that might be expected is the right ventricular failure. So if you have normal, if you consider the right ventricular systolic pressure above 35, this is considered normal. And if it is 35 up to 45, it's mild. And if it is up to 60, it's moderate. And if it exceeds more than 60, this is a severe. And those actually what might really observed in our clinical settings or in the GB practice, according to the symptom that the patient started to present with in GB practice in general. So if it is usually the mild degrees, actually patient having breathless or maybe dyspnea and generalized fatigue, and it might go up to the severity of having like angina or syncopal attack, and sometimes they get dyspneic and becomes cyanose even in room air as well. And definitely if the patient start to develop right ventricular dysfunction, you should expect that you have all the clinical setting or clinical observations of right ventricular failure, like congested neck veins, S3 gallops, pulmonary edema, and peripheral edema as well. But definitely, to be more specific, you have to rely on the echoes in general, echo or maybe the transesophageal echo, or the two in general. And there is some certain parameters and diameters actually you rely on in order just to be quite sure and very sure about your diagnosis. So it initially start simply by the tricuspid gauge peak velocity, and if it exceeds more than 2.8 meters per second, this actually is considered pulmonary hypertension. Also, if there is a flattening of the intraventricular septum, this is one of the main parameters or one of the main markers for that. The RV to LV diameter ratio, if it is above 1, this means that the RV now is getting bigger compared to the LV, which is not really the case in the normal situations. This means that you have RV failure. If you have a BA diameter more than 25 millimeter, or the IVC diameter, IVC means the inferior vena cava diameter, more than 21. Some of the researches actually went up to 22. So anything above 22 considered really as a significant finding that actually diagnosed the pulmonary arterial blood pressure increase. Blunted inspiratory collapse as well with the IVC from 20 to 50, and we'll see this later actually for the high probability of developing the pulmonary hypertension in general, and also the TAPC if it is less than 1.7 and even less than 1.5 as well, which indicates the right ventricular failure and right ventricular hypertrophy as well. We should consider also talking about the high probability of pulmonary hypertension, and simply you rely mainly on the peak TR. If it is more than 3.4 meter per second, it indicates high probability. But if there is decrease of the tricuspid regurg peak velocity less than 3.4, then you should never consider this as a sole indicator for the high probability of developing pulmonary hypertension, because simply you should rely on other echo parameters as well. Simply, if you have it's still above 3.2, this is definitely a high probability of developing a pulmonary hypertension. And if it is actually a range between 2.8 and 3.4, depends if you have the two echo parameter, then will be this considered as a high probability. If not, this is intermediate probability. And definitely, if it is definitely a less than 2.8 and you don't have more than two echo categories or like two other remarkable findings in the echo, then consider low one. Those are additional markers could be used as well if you want just to go a bit more specific in order just to diagnose the high probability or consider the occurrence of pulmonary hypertension. And that definitely relies mainly on the quality of the signal that you can get from your echo or from the TOE in general. So simply the ventricles go immediately with the flattening of the IVS. That's more specific and more really diagnostic and more informative compared to the RV or LV basal diameter. As I mentioned that actually earlier. So if you have the RV getting more dilated compared to the LV, the ratio is more than 1, this means really you have a pulmonary hypertension. Secondly, or the category B, the pulmonary artery, and if you have right ventricular outflow Doppler acceleration time more than 105 meter per second, or if you have an early diastolic PR, or pulmonary regurg velocity more than 2.2, this means there is a regurg from the pulmonary artery, and that means that actually you have a pulmonary hypertension. There is a resistance in pulmonary vasculature which causes a regurg going through the pulmonary valve, and that will cause increase in the diameter of the pulmonary artery more than 25 millimeters as well, which indicate another indicator for the pulmonary hypertension. If you want to go for the IVC and the right atrium, definitely it's very diagnostic. And if you have an IVC diameter which is more than 21, 22 maybe millimeter, and with a decrease in inspiratory collapse, if it is less than 50% in the sniffing position or less than 20% in quiet respiration, this is really an indicator as well. Also, the right atrial enlargement. That means actually if you measure the right atrial area, let me go back. Yeah, if you have a right atrial area enlarged in the systole more than 18 centimeters, this means actually you have right atrial enlargement, and this definitely, along with the other or additional to the other parameters, consider the pulmonary arterial pressure. And definitely that what ends actually by the development of the right ventricular dysfunction, and what causes actually right after right ventricular increase in the afterload and hypertrophy, and ultimately a dysfunction. Simply just during the septal wall movements as well, it might really indicates and might really helps to diagnose the right ventricular dysfunction, and indicates also the right ventricular afterload. And the difference actually simply is the right ventricular, if it is a volume overload cause, that will actually be more obvious during the diastole, and the left ventricle looks like a letter D. But if there is a pressure overload, there is a shift in the septal wall, mainly during the systole, because the pressure means contractility, and there is systole is a contractility, and that's what caused the shift during the systole. So this is a pressure overload. But in the case of a volume overload, it is a kind of a reservoir action, inflation, and it goes with the letter D. And you should rely also on the TAPC. TAPC means the tricusp annulus systolic excursion. So if it is more than 1.9, this is normal. If it is less than 1.5, this is abnormal. And if it is between 1.5 and 1.9, it's a borderline. Simply how it looks like. This is a normal LV, and the other one is a failed LV with a failed RV as well. And it shows how the septum is being flattened and the D shape as well. This is also a TOE image for the RV failure. And it shows really how the RV been struggling and how the LV even is struggling with the low volume as well. Simply, if you want to go for the treatment, you are dealing with the pulmonary vasculature, with the blood vessels. So you just get all the agents or like all the drugs that might really affects the pulmonary vasoconstriction, prevents the pulmonary vasoconstriction and increase the pulmonary vasodilation, relax more the smooth muscles and cause more pulmonary vasodilatation, but with the various types of receptors, various sites of actions. You need to increase the pulmonary, as I mentioned, the pulmonary diameter, pulmonary vessel diameter, relax the smooth muscles in general. So you need to choose one of those drugs, or maybe a combination of those drugs actually. So prostanoids or prostacyclins analogs could cause vasodilatation and also cause inhibition of the platelet aggregation, which is definitely very beneficial. So you can use the epoprostenol or inhaled Elioprost. This is very common, especially the inhaled Elioprost could be used in neonates or in the congenital heart disease settings in general. Also, the prostacyclin IP receptor antagonist like Selexibag oral. It's an oral drug that's been used for a long-term usage of those pulmonary hypertension or chronic pulmonary hypertension. Endothelin receptor antagonists definitely have a very significant improvement of the blood vessel contour or the blood vessel, that cause blood vessel dilatation and has also some anti-inflammatory properties as well. And one of the main, actually most commonly used drugs is the busentan and ambrisentan as well. Calcium channel blocker is an old-fashioned, but it actually do the trick and do the wonder. So it helps to relax more the heart muscles and reduce the afterload. A good example for that is the amlodipine, the nifedipine, and daltiazem. But mainly amlodipine is one of the good drugs that we use for this settings as well. Phosphodiesterase inhibitors like sildenafil and tadalafil, and those are very famous in this and this type of management as well. Other IV medication that can be used intraoperative like milrinone, amrinone, or even the IV sildenafil in the severe situation, or maybe IV epoprostenol as well in the theater. Additionally to that, you can use diuretics, helps to decrease the preload and the fluid retention, and along with the very famous or a new generation of diuretics, the dapagliflozin, SGLT2 inhibitors, which helps to really, it's been highly recommended now in many countries actually, and many centers, cardiac centers, as well as for the treatment of the right ventricular dysfunction mainly, and especially if it's been this caused by the pulmonary hypertension. Digoxin as an nootrope and to provide the heart control could be used along with the other medications. Some of the patients actually require, especially if they are in category 4, 3, and 4, they might really need anticoagulants like blood. I mean, that actually helps to reduce the incidence of developing of this kind of microemboli and microthrombi in the very small blood vessels in the pulmonary vasculature as well. Simply warfarin or the other antiplatelet medication as well. Most of the phosphodiesterase inhibitors, like sildenafil and tadalafil as well, helps to clear the blood vessels in the lung and easily manage to increase the blood flow during and the streaming of the blood flow during the chronic, especially whenever we have a patient with a chronic pulmonary hypertension. One of the main treatments actually being used widely in the ITUs is the nitric oxide, and along with the G-cyclase and agonist enzyme like ricoguat, and also vasopressin. Although that the vasopressin is very famous to cause a splanchnic and peripheral vasoconstriction, but definitely have a significant pulmonary vasodilator effect. So it helps with the right ventricular dysfunction. Many references actually discuss the use of vasopressin as the first line of management in the ITU in general. Nitric oxide helps to cause a vasodilatation, inhibit the platelet aggregation, and reduce the cellular adhesion and activation, and have actually a modulation on the immune response against the coronavirus in general. That's what been widely used during the time of the COVID. The selection of the treatment, which is could be another question actually, when and how and where. Depends on the degree that if the patient is actually in higher risk or the low risk, and those combination of drugs actually mainly is being tailored according to the condition, according to the selection of the cardiologist, and might really ends at the end by atrial septostomy or maybe pot shunt or maybe lung transplant at the end as well. But the combination of the drugs, whether to use the pulmonary vasodilator alone, like sildenafil or tadalafil or like ilioprost or maybe Polstan or whatever, or maybe add another adjuvant like conjoined with that is actually like having diuretics like dapagliflozin, which has been widely used now. It's actually purely and basically depends on the assessment, the degree of the pulmonary hypertension, and how far you can keep this drug on in order to provide a very good control for the condition on the long-term use. The challenges for our anesthetic practice actually varies between having a surgical stress that can exacerbate the pulmonary hypertension, the development of arrhythmia. They easily can develop arrhythmia. Most of them, by the way, have AF. If the patient actually develop a kind of a very mild degree or maybe severe degree of congestive heart failure, if the patient have start to develop a myocardial ischemia in the late stages, delayed extubation, postoperative respiratory failure, and long hospital stay in the ITU, also one of the actually most significant and major and massive challenges. Hemodynamic instability throughout the procedure, and definitely, as I mentioned, long hospital and ICU stay, plus the cost of that. Ventilatory-wise, definitely volatile and held anesthetics actually is very beneficial for those patients, especially and the moderate and severe, actually, compared to the TIVA, by the way. So inhalation is actually is one of our main favorite mode of anesthetics compared to TIVA. The ventilatory strategies actually depends mainly on how you can tailor your ventilatory settings in a way that it might help to provide a good oxygenation, good ventilation, reduce the carbon dioxide, or like causing an optimum or optimizing the pulmonary optimizing the ventilation in a way without increasing the pulmonary arterial blood pressure, and also without increase the mean airway pressure or the peak airway pressure. So you can use the low tidal volume. You should never go with the peak airway pressure more than 30 millimeter mercury, and high FiO2 is definitely being required. Hyperventilation, keeping the CO2 between 30 to 35. Don't exceed 10 on the B, because as I mentioned, it might really have a negative and dramatic impact on the peak airway pressure in general. And definitely high B might compromise the preload and cause systemic hypotension as well. Monitors are quite important, and the pulmonary artery catheter could be used along with the CVB, PAB, and targeted therapy, in order just to tailor your vasopressors, the vasodilators, and fluids during the management inside the theater on the ITU as well. TOE, mid-esophageal fourth chamber, if you have a GA for a major case or the cardiac case in general, it might help you. If the cause actually is pulmonary embolism or pulmonary thrombus, actually that what might really helps to diagnose and helps also to monitor the progress of your patient. But Currently, the use of the pulse contour analysis might really limits the need for the usage of the pulmonary artery catheter in general, because you can rely on the parameters they can really retrieve from the pulse contour analysis, like Vigileo or Letico or Pico, and all those actually new module that's actually been available in the market now, widely in the market. Nitric oxide might be needed inside the theater, and this is how we can deliver that for us. Actually, we might really ask, or maybe in the ITU as well. I mean, post-operatively. So you have the if you can see my pointer here, and this is nitric oxide tank. There's a flow regulator assembly. There's a CBU or a unit that actually deliver the system, and there is a control or a ventilator can be connected directly to the ventilator, and they have a sensor for the nitric oxide and the oxygen and the nitrous oxide as well, and the flow sensor helps to monitor all of that, maintain the required dose for the administration of the nitric oxide, and that would definitely go to the patient, whether you're going to use this system in the ITU, which actually might really requires a very specific experience, and you should have a technician, or like maybe someone who have a good expertise in order just to connect that into your ventilator, or maybe get another ventilator from the ITU in general. The dose recommended to be not exceeding more than 20 ppm part per million. For very preterm infants, for instance, if you are working in the neonatology or in neonatal anesthetics in general, so it should be start with the 10 ppm and might be sufficient for him. Actually, you should never go beyond that. The treatment of that in the ITU should never goes up to 14 days, and hopefully there is a kind of improvement after 14 days of 10 ppm. Definitely doses higher than 20 ppm are not suggested, especially for the neonates, the risk of the toxicity, and you should outweigh the benefits against the risk of developing this toxicity. One of the main thing here is just actually how you can tell that this patient started to have this improvement. If your patient have a pulmonary hypertension and you started already decided actually to go with the nitric oxide. So if the PaO2 had increased above 20 millimeter mercury, increase in saturation above 10% from the original one, if the patient cyanosis, and if you have a severe pulmonary hypertension, then you should consider that there is some sort of improvement, and that actually this means that you are hitting the target or hitting the required actually parameters in order to tell that you want to start now to reduce or to wean down the nitric oxide from 20 to 10 ppm to avoid the further side effects in general. Side effects of that includes the methemoglobinemia, which is very famous. Inhaled nitric oxide at the level of 20 ppm or less could be safe, definitely. And as long as you have the methemoglobinemia not more than 5%, you are still in the safe side, because if it went above or beyond 5%, high up of 5% or maybe 10%, it might be fatal, really. One of the side effects, the free radical, that might really cause a neural tissue damage in general. It might really convert it into nitrogen dioxide and spontaneously when mixed with oxygen, and that also have a neurological negative impact as well. It might really have a platelet inhibition at the long run and with the higher doses as well, and be cautioned, especially if the patient have any potential of having a bleeding or maybe diagnosed with thrombocytopenia. Pulmonary hypertension in the settings of the thoracic anesthetics actually might be also risky and challenging. One lung ventilation should be avoided as much as you can. The use of the double lumen tube or the one lung ventilation in general. So blood flow, why? Because the blood flow decreases with a non-ventilated lung and definitely might exacerbate the pulmonary hypertension and actually because of the hypoxic pulmonary vasoconstriction. So you are adding more banning for the van. So, you're adding more band for the van. So you cause more pulmonary vasoconstriction for our already pulmonary vasoconstricted vasculature. So it should be or better to be avoided. Right, especially, but cause an increase in the right heart afterload, and that definitely might compromise the cardiac output in general. Surgically, if you fail with all of the earlier maneuvers, atrial septostomy, simply you create a kind of a septum BFO, like intra-atrial septum defect, to release the pressure from the right side of the heart, or maybe finally it might really end by the need for the lung heart transplantation. Take home message, actually, unfortunately, even if our best efforts, complication might really arise with those patients, including the right side heart failure, or maybe development of the arrhythmias, systemic hypotension, especially if they have a suprasystemic pulmonary hypertension. And definitely another anesthetologist must avoid the exacerbation of factors and control all those potentials in order to, throughout the procedure, in order to achieve the outcome at the end. It's a matter of balance, actually, between the blood pressure, the fluid use, don't overload the patient, the oxygenation, the ventilation, the pH, avoid the acidosis or anything that might actually compromise the acid-base balance. Also, the peak airway pressure as well, it should be optimized. So it's a matter of balance. And that's all for me, and thank you so much. I wish if you have any questions, I'm on the ground, we can start now. Thank you.